Let me see that move, Sterling.
Oh, net.
Kids and sports, such a great combination, and such a great opportunity for injuries.
With the increase in the sports activities and the kids starting younger and playing more and year-round and all of that, it's definitely having an impact on what we see here in the clinic. Soccer, basketball, football, wrestling, we've seen injuries out of all those kids. Primarily, I would say knees, ankles, hips, every once in a while, shoulders.
For 17-year-old Sterling, it was a knee injury. It happened while playing his favorite sport.
I was playing basketball, and then there was a dude in front of me, and then I tried to go behind him, so I ran behind him, and I tripped sideways, and then my knee popped. I heard a loud pop, and then I went to lay on the ground, and I couldn't bend it or straighten it.
Any sort of activity that's a cutting, fast side to side, quick stops, jumping, anything with change in direction puts a lot of stress on the knee, and these sorts of injuries are really common in those sorts of activities. So we see them on the playground, but often it's with some sort of activity where the child's changing direction fast or landing off balance from a piece of playground equipment.
Initial treatment involved ice on the knee, ibuprofen, and pain medication.
And every night,
Yeah.
waking me up at 1 o'clock in the morning, calling me on the cell phone to the bedroom. Dad, do you have another ibuprofen? Would you please bring me one? You know. And I'd get up and take care of him and get him a fresh bag of ice.
Yeah.
Make him prop it up.
So
Hey, thanks, Dad.
Almost as bad as the pain was not being able to play basketball. Sterling's best friend Ricky understands.
Basketball just takes you away from all your problems, just puts you in like away from the world, on top of the world type of feeling. And then once you're like on teams and you got plans for like going somewhere, it's just like a challenge.
How are you guys doing today?
When Sterling's knee didn't improve, his doctor at Odessa Brown Children's Clinic referred him to Seattle Children's Hospital for treatment. An MRI revealed a lateral meniscal tear.
You can see the end of the thigh bone here is fairly rounded, and the top of the leg bone is quite flat. And to make those two surfaces match, there's soft tissue cartilage called the menisci, and those rings of cartilage serve as bumpers, and they help distribute the forces between the rounded end of the thigh bone and the flat top of the leg bone. And in Sterling's case, he had torn his lateral meniscus. It had torn right off its attachment to the tibia and was folded in, and that was blocking his motion. And so our job was to either trim it out if it wasn't repairable, or fix it and repair it back to where it belonged, with the hopes of preserving this bumper to reduce the risk of arthritis as he got older. Here's his MRI, and we're looking at a side view, and this is the inner side of his knee as we come across, and here's the inner meniscus, the inner ring, and it looks normal. We see a little triangle in front and back. And then we see, here's his posterior cruciate ligament, and that looks normal. And here's his anterior cruciate ligament, and it looks normal. And then there's this structure that shouldn't be there, and that's the flipped up meniscus.
They showed us a picture of the knee and explained all the different parts of the knee, how it works, and what to expect and all that stuff. So,
Orthopedic surgeon Dr. Gregory Schmale recommended surgery to return the meniscus to its normal position. And as he explained to the family, it was possible that Sterling's anterior cruciate ligament had been injured as well.
The radiologist had read that the anterior cruciate ligament was at least partially torn, and whether that's going to be a functional problem for him, whether that's going to produce instability of the knee, will not be able to be assessed until we get that meniscus, I think, out of where it's stuck right now.
So Dr. Schmale, what are we talking as far as recovery time?
Well, it depends on what we do. If we repair the meniscus and the ACL seems okay, then we have a rehab program it's 6 months until we'll allow him to squat with weight bearing. So it's pretty much a 6-month rehab. And if we do an ACL reconstruction, it goes to 8 or 9 months.
Dr. Schmale is using a minimally invasive arthroscopic procedure on Sterling's knee. The arthroscope, carrying both a miniature camera and precision surgical tools, is inserted into the joint through a small incision.
So this is the piece of meniscus that's not where it should be. It's flipped all the way around. This is the outside of his thigh bone, the lateral femoral condyle. And this meniscus is all the way across.
Pediatric sports medicine is a growing specialty at Seattle Children's Hospital. It's a large part of Dr. Schmale's practice here.
For a lot of young people, playing sports more months out of the year means greater skill and a greater speed of play. And with the greater speed of play comes greater energy of injuries, and we see more adult-like injuries.
The injuries may be similar to adults, but the bones are not. Orthopedic surgery for children and teens is often complicated because their bones and connective tissues are still growing.
If we look at the end of the thigh bone and the top of the leg bone in a child that's growing, there's a stripe of cartilage that lives a few centimeters from the joint. And that stripe of cartilage is the source for new bone that's formed and is pushed away from the knee joint in both directions.
Sterling's leg bones are more like an adult's, so the growth plate isn't a concern in his particular case. And the surgery revealed that his ACL wasn't injured after all.
That's his anterior cruciate ligament right there, and that looks really pretty good. There was a question as to how healthy was it, was there a partial tear, and it looks just A-okay there. So this is a pretty neat part. It just shows how we're stitching the meniscus. And there's the suture. And then
Before becoming a surgeon, Dr. Schmale was a science teacher. That experience serves him well as he interacts with young patients and their families.
We're answering lots of questions and trying to explain what's going on. And I think one of the great reminders for me is to see a child light up, that they are clued into what we're talking about and interested and invested. And I think to get the child involved is huge, and to get everyone on board in the family is important. Hey. Dr. Schmale, everything went fine. He's doing swell. Yeah, he's in the recovery room.
Sterling will wear a brace on his knee for a while, and it will be months before he can be involved in sports again.
I know he likes to play basketball and do those things, so that'll be a challenge.
And there will be physical therapy, which starts here at the hospital. A comprehensive team approach makes it easy for therapists and physicians to work together.
It's like a one-stop shopping here. They can come in and they can get their crutch training, they can get their casts on or off, they can have their x-rays, they can see the doctors, and then they come in here for therapy. Okay, and got you at about 90, 93. So that's great.
Like Gregory Schmale, Janet Morton's special area of interest is sports medicine for children. She works with athletes from toddlers to teens.
This is, if you feel like you're having a hard time getting your knee completely straight, okay, this is a good way to stretch it. You can just lay on your stomach. If you have a little weight at home, put that weight around your ankle and just let that kind of pull so that you're really, does that hurt a little bit? The PT is really important. It's very important. And you know, you do the surgery and you fix it, but when you go in and change the joint or cut the muscles or whatever has been done, they need to build that strength back up. Some kids can do that a little more independently than others, and some kids need a lot of hand holding. So, and I've had a wide variety. Okay, we'll go one more minute.
2 weeks after his surgery, Janet checks on Sterling's progress.
When someone like Sterling comes and he's 2 weeks post-op from lateral meniscus repair surgery, you know, they're still fairly limited in what they can do. So I will, first of all, look at his knee, check to see how much swelling there is, check his range of motion, make sure he's where he should be with range of motion, and if he's not, then I would give some exercises that specifically address getting that range of motion going.
Older teens like Sterling can usually take responsibility for doing their exercises. It takes special skill for Janet to work with some of the youngest patients.
The younger kids who need a lot of therapy can be challenging, but there are ways to do it, and you just have to be creative in finding things that they're interested in.
Keeping kids interested and engaged is a priority here. It shows in the halls, in the exam rooms, and in the people.
The people are, that's all they do is take care of children. You know, there's more, you know, than physical differences in adults and children. There's also emotional and psychological and developmental differences.
Seattle Children's Hospital has specialized in pediatric care since it was founded in 1907. From the very beginning, orthopedics has always been a major focus. Bone and joint repairs are common medical procedures for children.
One of the very interesting draws to orthopedics is the variety of types of patients that we would take care of, from the run-of-the-mill, in-towing, out-towing patients to the very complex spinal deformities and limb deficiency patients.
Dr. Klane White has a particular interest in treating spinal deformities and genetic disorders. Research on what causes these conditions is part of the mission here.
We know how to treat children orthopedically. We know how to treat deformities, and we have a good understanding of what will work and what won't work. What we don't understand is why it happens in the first place, and whether there are manipulations that we can do that are non-surgical so that children can avoid big surgeries for their deformities, whether that be in their extremities or their spine.
Besides the sports injuries and genetic deformities, the active lives of children sometimes cause broken bones. The emergency department here is frequently busy with orthopedic cases.
The most common fracture we'd see would be a forearm fracture. And the second most common would be an elbow fracture. And then there's femur fractures. These are isolated injuries for the most part, falling from playground equipment, falling from furniture, falling from anything.
Tonight, Dr. White is on call for emergency orthopedic surgery.
Sarah, Klane White.
10-year-old Sarah has a broken leg.
I was on a bench, I tried to jump, and I fell down on the ground.
Take some deep breaths.
Young patients brought to the emergency department at Seattle Children's Hospital have access to an entire range of specialty pediatric care, including immediate orthopedic surgery.
In pediatrics, we're able to take care of the whole child, the whole person. We can offer a whole array of services in addition to our orthopedic care, particularly for the complex children who have multiple medical needs, and we can coordinate their care with other services that are available at our hospital.
Caring for the whole child also means calming the fear that comes with illness or injury.
I explain to them what we're doing in rather simplistic terms, that they will go to sleep and they will wake up and they'll have a cast on. And I spend a lot of time reassuring them that we will take care of them and that we will keep them comfortable and happy. And I think we can do this without sedating her. Okay, she seems pretty comfortable. We'll be very gentle, and what we'll probably do is just have you scoot over to the edge of the bed and we'll go ahead and roll a cast. Okay.
Often, frightened parents need reassurance as much as the young patients. Comforting them and working closely together is part of family-centered care.
One of my partners is very fond of saying, you're never taking care of one patient. There's often 2, 3, 4 patients, including mother, father, grandparents. And it's a bit of a skill to be able to communicate with families and making everyone comfortable and be educated about what's going on. And then particularly taking care of children. I think that's just something that some people have a natural knack for.
Many patients come to Seattle Children's Hospital from Montana, Idaho, Alaska, and of course throughout Washington. These 4 states make up the largest referral area of any pediatric hospital in the country. Children's also sees patients from other states and from around the world. Katie was referred here by a physician at her hometown hospital. She has a broken femur, and Dr. White is operating on her tonight.
I was getting down from a treehouse, and my friend were getting down the other way, and then I'm like, I'm gonna get down faster than you. And then I was holding off a branch, and it fell off, and I fell backwards on some boards. I tried to get up, but it felt so weird, and it hurted, so I couldn't.
This is actually a pretty common fracture that we see in children, and this was pretty typical. She's still a skeletally immature girl, so we have to use the techniques in which we avoid the growth plate. Actually, let's bend the tip of this a little bit.
This procedure is an intermedullary fixation of the femur. With this type of surgery, there's no need for a cast.
To put her into a cast, she'd have to have a cast that went up around her waist and all the way down to her ankle. And by doing this kind of surgery, now she has no cast. And so she doesn't have to try and get up and walk around with a 20-pound cast. Shot.
The surgery involves inserting metal rods in Katie's leg. She'll be in the hospital for a few days, then use crutches in a wheelchair as she heals.
That's pretty nice there. Shot. I like that. Save that, please. Her fracture will probably heal in about 6 or 8 weeks, and
It will fully heal and remodel within about 9 months, at which time we will take the rods out. You don't have to take the rods out, but most pediatric orthopedists, I think, are of the belief that children should be grown-ups without implants left from their childhood.
There's the crack right here. See this? And that's right here on my knee, and they did it right here on 2 sides. They did 2 holes so they can put the pins through this side to that side and this one to that side. The pins are right here. They go like that, like 2 waves across. So this is like my whole bone in here, and this is my leg. And it was when I first fell off, it was like, you know how it's usually like this big, and it's like it was this big, my leg.
Hey Katie, how are you?
The next morning, Katie is much more comfortable. She's happy to talk about her surgery and very happy not to have a cast.
I didn't really want a cast because it's like weird with a cast, and going to church is not like really pretty, or going to a store.
So I'm going to lower the crutch to this level, and I'm going to lower it 1 more.
Okay.
It's a little bit tall for you.
Like Sterling, Katie has some work to do with her physical therapist. Today, she's learning to use her crutches.
So let's just stand up for a minute on your left leg and put the crutch underneath your arm.
In a few days, Katie will go home. She'll be out of her wheelchair and using crutches by the time she starts 6th grade.
You're doing great.
And when the rods come out in 6 months or so, she'll have a souvenir to show her friends.
When they're gonna take it out, they're gonna give me the medal. I think I'm gonna like set it in my room or like set it somewhere in my house so my friends can see and ask me questions what happened, because I like when people ask me questions.
Hello. Hello. Hey, Sterling. How are you doing?
Orthopedic surgeons at Seattle Children's Hospital follow their athletic young patients through rehabilitation.
How's the knee holding up?
Pretty good.
Is it good? Are you having problems with popping or clicking or clunking or anything?
I can't jump off both legs yet, but I'm fine.
It's been 8 months since Sterling's knee surgery.
I have good reason to believe his meniscus is healed up. He's not having any symptoms, not having any swelling in his knees, not having locking, painful popping, catching. And so those are all good things. Give me 3 hops for distance on your good leg here.
Because Dr. Schmale chose to repair rather than to trim Sterling's meniscus, rehabilitation takes a little longer than it might for an adult patient. Today, Dr. Schmale is assessing the results of physical therapy.
Yeah, you're short by a lot, huh? They usually make you pass the hop test before you return to sports, because you're at risk for injury if you're that much weaker on the one side. But therapy just doesn't get along with some people. And it may be that playing basketball would be a good way to build your strength back.
Athletes typically have to pass the hop test before going back to playing in competition.
That's 1.5. So you're pretty close.
By allowing some less strenuous practice, Dr. Schmale hopes that Sterling's love of basketball will inspire him to do the exercise he needs to rebuild his muscles.
He said I have to work at home, or else physical therapy is not going to help me that much, and I could start playing basketball, but not that much like I like to.
The rehab is huge in terms of trying to get him back. He's still not back to where we would hope, but I think at this point his repair is safe for him to advance his activities to a degree, and I'm hoping that with some basketball his quad strength is going to grow.
And that's just what happened. Expert medical care, combined with an understanding of the teenage psyche and the special needs of young athletes, puts Sterling back in the game. And Sterling is just happy to get back to his favorite sport.
I'm completely healed, and I'm free to go back to sports again.
For more information or to make an appointment, call the Orthopedics Department at Seattle Children's Hospital, 206-987-2109, or visit http://orthopedics.seattlechildrens.org.